Okay, when you ask me about the type of breast cancer, you are referring to the unique features of cancer cell under microscopic view. When you look under the microscope, the cancer cells type. Okay, but patients sometimes confuse with grade and stage. So grade, they are looking at the activity of the cell, whether it's high grade or low grade. So that's different from type. And staging is looking whether the cell has spread to like other organs or lymph nodes. So type is basically divided into two types. There is the non-invasive type and then there's the invasive type. The non-invasive types means that there's abnormal cells within the milk duct and it hasn't left the milk duct, it's still within inside. And this is called precancerous. It has a potential to become invasive and cancerous, but for now it is not invading other areas. Then the invasive types are the cancer that has grown out from the milk ducts to the surrounding fat and also go into the lymphatics and the blood vessels. This type of cells can carry this type of carcinoma can go to other organs. That's the risk of spreading. So within the invasive, there is two common subtypes. Two common types, there is the ductal and the lobular. So the invasive ductal carcinoma accounts for about 70% of breast cancer and the invasive lobular carcinoma accounts for 20%. Of course, there's a minority, like 10% of rare stuff like sarcoma. Okay, within the invasive carcinoma, there is always other subtypes. We classify into 4 subtypes. If you look at the table that is projected, there is lumina A, lumina B, HER2, and triple negative. How they classify the subtypes is estrogen receptor ER, progesterone receptor PR, and HER2 overexpression. You need to go through this with your oncologist to subtype your breast cancer. Okay, very important is to understand the diagnosis. You need to look at the pathology report in detail. You need to talk to the oncologist to see what is the size of the tumor, whether the lymph nodes are involved, whether there's any abnormal features. If it's in doubt, then maybe second opinion is needed. And then, of course, within the pathology report, you will understand whether you are hormone receptor positive or HER2 overexpression, and thus do the subtyping. This is very important because it decides on what treatment you will be needed later on. Then once that's done, the oncologist will probably ask you to do a staging scan, usually a CT scan or a PET scan. This is to see whether the tumor has spread to other organs or not. And subsequently, of course, we need to check the fitness. If patients are planning for chemotherapy, we need blood tests to check on the liver function, kidney function, and also we will need to sometimes check on the heart condition to make sure there is nothing that is hiding around the corner, because sometimes chemotherapy will cause heart problem also. And then nutrition is also very important. Patients shouldn't be underweight and they should have a very good balanced diet. And lastly is whether their emotions are affected. If their emotions are affected, they should get counseling. They should have a positive mindset before they start their treatment. Okay, the mainstay of treatment is still surgery. It's usually done before all other treatment. But however, there's certain situation where the breast surgeon might want to do chemotherapy first before the surgery, especially tumor that is very big or tumor that has involved the lymph nodes, or even if cancer has spread elsewhere. So we will usually do chemo to shrink the tumor and then go for surgery. But surgery is always the first to be done first. Then this is followed by chemotherapy. Chemotherapy is usually indicated for more advanced cancer, usually when the lymph nodes are involved or they are of high grade, or certain subtype like triple negative or HER2 overexpression type. You need to discuss with your oncologist what is most appropriate for your subtype of disease. And the third one will be radiotherapy. Patient who has lumpectomy surgery, they will definitely need radiotherapy. If they do not have radiotherapy, their outcome will be inferior to mastectomy. However, patient who have mastectomy doesn't mean they don't need radiotherapy. Those tumor that is big, or that's lymph nodes involved, or the margins involved, even after mastectomy, they still need radiotherapy. The fourth will be hormonal therapy. Hormone therapy are only for hormone receptor positive patient, like estrogen receptor positive, progesterone receptor positive. And the last will be anti-HER2 therapy, which is for the HER2 overexpression type. I think support without judgment. So a lot of time, I do have patients with the family coming in asking the question, why it happens to the patient, what is the cause of it? And then they will say, is it because patient don't sleep well, they don't eat well, or they are overstressed? This is blaming the patient. They're trying to find a reason to blame. So don't judge the patient, don't blame the patient. It's not fair because patient did not choose to have this disease. And then respect the patient's decision is very important. After discussion as in what to do next, what's the treatment, sometimes the patient's voice is very important. You must respect the patient's decision. And then, of course, accompany a patient to the doctor's appointment, because when patient is in the clinic, sometimes they are blank. They appear to be sitting there, but actually they are not absorbing whatever information you're telling them. So being in the doctor's clinic with the patient, they can take notes, they can lend an ear, they can further understand the situation and help to make decision. And also, I guess, spend more time with the patient so that the patient don't feel that they are being abandoned. Especially old people, they always say, I don't want to be a burden to my son, my daughter. I think we need to do more self-breast examination monthly. Just feel your breast during your showers. If you feel that there's anything suspicious or anything you're not sure, you feel it's there but not there, seek medical advice. Better be early than late. And also, according to the MOH guideline, they have a breast screening protocol. I do recommend a patient to refer, or any female to refer and follow the protocol. I think they suggest 2 yearly mammogram for normal risk patient after 50 years old. And if patient is high risk, let's say the family member has breast cancer, then they should do it much earlier, maybe at about 40 years old. It's very important to be positive and be brave. You have to be brave to face the diagnosis, be brave to face the treatment that is needed, so that you can go through with confidence, and also be strong, because the journey is not easy and they need help. You should get some peer support group to talk to survivor, get their advice.